So what is cerebral oximetry? It utilizes the principle of infrared light, that how it is differentially absorbed by oxygenated and deoxygenated hemoglobin, and thereby it gives you a number and how you can use it. There are multiple studies, and I'm just going to show a couple of them in the interest of time. This was an adult study where they looked at the cerebral nares, and if the cerebral nares came down or if there was a rapid change, they did some interventions like increasing the flows, giving PRBCs, and if there was still no change, then they took them down for CT imaging and found that these patients had infarcts. And this is a pediatric study published by the Mirab MBA's group, where they showed that the mean SO2 was lower in the non-survivors, and among survivors, the lower SO2 was associated with poor neurological outcomes. We have utilized the cerebral oximetry as their relationship with blood pressure as a correlation. And we use that as a surrogate marker of cerebral blood flow. And we said if there is a correlation between cerebral oximetry and blood pressure, we measured called the autoregulation index, and we showed that if there is a higher autoregulation index, it was associated with higher neuroimaging scoring. And you can see a few patients in the gray bar on the left. I don't know if there's a pointer. And I think there's a pointer. And these were patients who, of the 5 patients, 4 of them were cancer patients, and 1 of them was a neonate with GBS meningitis that we didn't know prior to putting the kid on ECMO. But otherwise, it seemed like the autoregulation index correlated with neuroimaging scoring. Then we went on to look at the W-Cox index, which is a correlation coefficient index between blood pressure and cerebral oximetry, and compared that with the blood pressure, which was normalized according to the age. We used patients with no injury as a control, and then we looked at the ischemic patients, which are represented in the gray squares, to hemorrhagic patients, which are represented in the dark triangles. And we found that the ischemic patients had loss of autoregulation in the lower range of blood pressure, and the hemorrhagic patients had loss of autoregulation in the higher range of blood pressure. So if you had to, all of us are very familiar with this cerebral autoregulation curve. So if I had to take the patients, I would say that the ischemic injury probably lies in this part of the autoregulation curve, and the hemorrhagic injury patients probably lie in this part of the curve. So then we now have our own funding for diffuse correlation spectroscopy. I'm not sure how many of you were in the research session. One of our faculty, Ethan Sanford, just showed our pilot data on utilizing diffuse correlation spectroscopy as a surrogate marker for cerebral blood flow. Here you measure the movement of red blood cells, and you use that as a surrogate marker. And we found that we measure that as a movement of the blood flow against the blood pressure, and we call that the DCSX index. And this is an example of a patient who is on ECMO, and as you can see, this measurement versus this measurement, there is no clear correlation. And the same patient, a few hours later, you can see that there is a significant correlation, which means probably their autoregulation is abnormal. And we have now done this pilot study. This was a patient, 24-month-old, with septic shock who went on ECMO, and we consented this family, and we obtained this DCSX index. And you can see this was pretty high. Anything greater than 0.5 is considered higher. And then once we stopped the paralysis, we noticed that the patient was not moving the right side of the body. And then when we got the CT, we found that there was a big ischemic stroke, and this is the post-ECMO MRI. And a similar 19-month-old with ARDS who had to go on VA ECMO, and we did the DCSX measurement. It was pretty low, and the post-ECMO MRI was unremarkable. So I think hopefully I have, this is a pilot data that we have done on 15 patients, where we have now correlated this mean DCSX index with neuroimaging scoring, and we found that patients with higher index had higher neuroimaging scoring. So I think we've shown that both NIRS and DCSX monitoring can be useful to identify patients before maybe they can, before we can clinically recognize injury. Then we went on to ask, can we predict who is at risk? And then can we identify some modifiable risk factors? In an attempt to do so, we have utilized some artificial intelligence, And this is an initial study that we published using our center data, where we had 174 patients. We took hourly data on 36 different variables with 40,000 ECMO hours and 1.2 million individual data points. And you can see that this is some of the ACROC curves, the numbers that you can see. It was very good at predicting who was not at injury and somewhat good at predicting who was at injury. We grouped the different variables, and we used what is called a permutation feature importance analysis. And we dropped each set of variables, and we said which one was important. And when we dropped the physiological data, the model was useless. And coagulation parameters, unfortunately, did not pan out to be an important set of features and was low in the risk category. So then we said we are going to do the same thing with a large number of patients, but with fewer data points, utilizing the ELSO registry data. And so far, this is still unpublished data again, and we have come up with some scores, and as you can see, these are some of the factors, and we used separate ones for VA and VV ECMO patients. You can see the trained data is represented in dark circles, and the test data is represented in gray circles. And I think it is certainly helpful, at least in the higher score range. These were patients who were at significant risk. You can see the fraction of patients with neurological injury. The higher the score, the greater is the risk for neurological injury. And when we did this for VV patients, the factors, the pre-ECLS and on-ECLS factors were slightly different, and the scoring was also slightly different, and maybe not that great for VV patients. But I want to point out that here, though our patient numbers were higher, we had only one data point, pre-ECLS and on-ECLS. So hopefully, the conclusion that I have is that neurological injuries, all of us agree that is a significant source of morbidity and mortality. There is a need for better neuromonitoring strategy so that we can identify the patients before it is clinically apparent. And at least in pediatrics, we have shown that clinical ability to recognize neurological injury is not that great. And maybe this will be an opportunity for us to utilize the wealth of data that we get on these patients to come up with a prediction modeling for these patients and say, can I identify at least 2 or 3 risk factors that then I can potentially do an interventional trial. So all of this work could not have been possible with the help of so many people that are listed here, and the grant support, including the ELSO grant and some of the foundation support, and now we have NIH funding. And last, but certainly not the least, all of our children and the families and the wonderful staff that I work with. And I'm happy to take any questions in the end.
Thank you so much for everybody welcoming me kind of out of my field here into the ECMO community. Sometimes people call me and my colleagues and always worry about us asking you to stop anticoagulation. They fortunately asked me to talk about a topic that we're kind of working in the same direction on. So my disclosure, I work with a company on hydrocephalus treatment, so it's not related to this. So why do you care about what I'm talking about? So in a number of single institution studies, they do have some reports of probably about 10% rate of ischemic stroke during and after ECMO. And in the ELSO registry data set itself, we do see somewhere between 2 to 4% rate of ischemic stroke with ECMO, a little bit higher in the VA population and slightly lower down towards the 2% range in the VV population. So sometimes there is ischemic stroke in these ECMO patients. In this roadmap, we have you all kind of working on the pathology, treating it with ECMO. Kind of in the top right corner, these are some of the good outcomes, occasionally a bad outcome. But then somewhere, there's also this stroke event. And I'm down here on the bottom right corner with my neurology colleagues working with IV TPA and thrombectomy. So where's the bridge and how do we connect to each other? And I hope to bring us together with this talk. So at the end of this conversation, I want to make sure that you have this core message. One is that if there is a thrombus or an embolus that blocks the intracranial circulation, we do have effective and well-proven techniques to treat this minimally invasively using endovascular strategies. And these are actually congruent with ECMO and also with TPA. So unlike when you have a patient with hemorrhagic complications of ECMO, we are doing a percutaneous transfemoral or transradial, or in some cases transcarotid access, and we want more anticoagulation, not less. You'd heard me talk about a couple of different access strategies, so no matter what cannulation strategy you have for your ECMO, we will find a way to work around that and recanalize any cerebral vasculature that's occluded. And why do we want to be doing this? There is, not in ECMO-specific patients, but in adults, level 1 evidence that supports the removal of this. And as a comparison with something that the ECMO community is probably familiar with, PCI for STEMI, the number needed to treat for improvement in outcomes, somewhere between 15 to 20. The number needed to treat for a mechanical thrombectomy for large vessel occlusion of the brain is somewhere between 3 to 10, depending on what studies and how selective you are about your population. So we have a highly effective, proven way of addressing large vessel occlusions in the brain. So I'm down there on the bottom right in thrombectomy, so I want to bring you all there. I want you all to be wanting and maybe doing thrombectomies. So these are things like gas bubbles, thrombi, or other particulate matter that generally are filtered out, but sometimes can make it through the system and into the cerebral vasculature. I stole this from the literature, so panel A here has a nice white arrow that shows all of us on this AP projection of the cerebral angiogram of the carotid artery, where that MCA is occluded and not perfusing the territory. After mechanical thrombectomy by this group about 2.5 years ago, they reported and they show complete recanalization of that MCA territory. This next slide, I'm actually going to actually, in a couple slides, I'm going to ask for help from our imaging people, I think. So how do we get that done? What are the equipments? What's our access? I show here just a transfemoral approach, which is the most common in children, and until about 3 years ago was also probably the most common in adults. Nowadays, transradial has really dominated, but it's a percutaneous access. The types of systems we're using are 6 and 8 French systems, so tiny compared to the cardiac intervention catheters that are being used by my colleagues in this room. That top right corner shows one of those example catheters, and 070, 072 diameter catheter, and then sometimes it's a direct aspiration, and sometimes we add on this device that you see highlighted in yellow, which is a stent retriever. It's not deployable, it just opens up, and when you pull it, it pulls the clot out with you. On this left-hand side of the panel, I have a demonstration of a case that I did last year. So I have highlighted in blue that catheter coming up from the left vertebral artery into the basilar artery, and then following further, let's see, a little bit further upwards, we have the green line showing that stent retriever device. You see these 3 dots here, 3 dots here, 3 dots here, and 3 dots there. That's that stent retriever opened up across this red highlighted thrombus. It's actually all black and white, so I never have someone color annotate it for me during the cases. Here we see that catheter is brought up transfemorally, or nowadays in adults transradially into the carotid in most situations. And let's see, sorry about that. Can I ask for do we have the ability, can you, in this panel here, sorry about that. In this panel here, yeah, if you play that out. So this is the initial diagnosis. We have this red circle here showing occlusion of the right side PCA. This next panel, if you play this video, we see now that vessel is visible and patent because we have the catheter up in the vertebral artery, the stent with the 3 dots, 3 dots, 3 dots into that vessel across that thrombus. And so it actually pushes that thrombus to the side and then allows us to retrieve that. So after all the catheters are pulled back and that stent retriever is out, now that's recanalized. So this is done in the order of 10 to 15 minutes in an ideal case. If you have multiple passes, it could take up to 45 minutes, but we're really measuring this in the order of minutes, right? So time is of the essence here. So how do we get from stroke to thrombectomy? Why do we know that this is important and effective? This is all really established back in 2015 with 5 serial trials that were published over the course of just 1 year, and showed that there's a number needed to treat that I cited earlier, somewhere around 2 to 3 for 1-point improvement in the modified Rankin scale. So this is functional improvement and independence. In the years since, there have been a couple more randomized control trials that extended on that. Those initial trials, about half of them used a specific cutoff of either 4.5 to 6 hours from the time of last known well to the time of diagnosis and revascularization. And these additional trials show us that we can still achieve a very low number needed to treat if we use selection based on advanced imaging, which is basically CTA and variations of CTA. In children, unfortunately, as is typical, we don't have good randomized controlled trials, but instead of 1,300 patients in 5 trials, we do have 300 retrospective cases, and we can talk about those outcomes as well here. So under 19 years old, we achieved still 75-85% technical success, meaning pulling that clot out, making the picture look nice, and 80-90% good outcome at 3 months post-stroke. And we can accomplish this with still low morbidity and mortality, so less than 1% with hemorrhages from the procedure and less than 2% with mortality after thrombectomy. This is actually better than what we saw in the adults, which was somewhere around the 70% functional outcome and approximately 1-2% morbidity and mortality as well. So why don't we see this more? Why aren't we doing this more? What are some of the barriers? And I'm really glad that that last talk talked about some of the innovations that we're working to identify these patients earlier and potentially allow us to intervene on them earlier. Again, we're talking about tens of minutes to hours for high success of this kind of intervention, right? So in a non-ECMO patient population, there's really 2 pillars of the diagnosis. One is clinical exam, and unfortunately, we don't have consistent clinical exam in some of these patient populations, although I'm heartened to hear about a trend towards more awake patients with ECMO or lighter sedation strategies. And part of the clinical exam is diagnosing the stroke, but then also in particular diagnosing when that occurred, because we want to identify these patients and treat them before completion of that ischemic stroke injury at a time when the brain tissue is still salvageable. The other pillar is the imaging, which is also limited in the context of ECMO. You see here I talk about CTA, MRA, and angiography. Really, MR is not an option here for these patients, but CT and CTA are not without their pitfalls as well. So you can look at hypodensities on a CT, that's stroked brain. I'm not helping that. You can look at CTA and look for the occlusion, which is absolutely critical before you take these patients for intervention. Otherwise, you're going to do a lot of interventions on people who don't have a targetable occlusion. And then in the non-ECMO population, there's a lot of data, those 2 trials that help us target late diagnosis patients based on perfusion parameters. Unfortunately, those parameters aren't likely to work in ECMO patients because the way that the circulation is altered means that there's left and right asymmetry of the cerebral perfusion, as we show in this nice description by the radiologist. Here we see the right side ICA, M1 and A1, being not well opacified, and in your neurosurgical colleagues who are looking at this might worry, hey, is that an occlusion? And it's important for you to remind them this picture is actually a result of the ECMO circuit and not the occlusion. So there's a number of pitfalls there that your typical neurosurgeon or neurointerventionist may not actually recognize in the diagnosis and use of typical imaging modalities. Areas of improvement already covered. I'll just say things like continuous EEG, NIRS, and NIR DCS. Potentially serological biomarkers may be helpful so that we're not taking as many patients. Transporting an ECMO patient down to CT scanner is not without its pitfalls as well. But ultimately, it's important to have your community engaged in those research trials, because I can only imagine that these biomarkers are not going to look the same in an ECMO patient as it would in a patient coming in from the street with a stroke. So again, what's the take-home message? If you have a large vessel occlusion with a mechanical occlusion, we have good ways of treating this and reversing that ischemia, and we can accomplish that with a minimally invasive approach that doesn't require stopping anticoagulation, so everything is congruent with the work that you're already doing for these patients, and it only takes a few patients in order to have a clear benefit in one of them. Thank you.
Thank you, everybody. And I know it's the last session, and we have an evening reception coming up. And this is an 8-minute talk, and I'm going to try my very best to do as fast as I can and not delay us getting there. Okay, so I have no disclosures apart from the fact that I'm part of the scientific committee for the EuroELSO, and I'm the section chair for cardiac ICU and mechanical circulatory support in the ESPNIC. So ECMO, of course, we all know this really well, life-saving, complex, resource-intense, and we all know that for the right patient, it brings great dividends. But we also know that there can be complications, and neurological injury related to ECMO is well known, and you've already heard so far, you can have a bleed, an infarct or edema. These are all scans from children and supported on respiratory ECMO neonates. And I show you here a series of scans on a 1.5-year-old child, post-cardiac ECMO. You can see that this child had a mechanical valve and difficult anticoagulation, acute failure of the valve, emergency ECMO, and you can see the series of scans showing small infarcts, and then the child gets decannulated, excellent, and then has an MRI, and then finally what results in a poor outcome here is a severe intracerebral hemorrhage, which is fatal for this child. So we have heard this before. There are multiple factors which are responsible for neurological complications, and these factors can be pre-ECMO, on ECMO, and even post-ECMO. Now, some of these we are unable to modify. It could be the congenital syndromes, the underlying disease, the way the child presents, pre-ECMO, severe hypotension, acidosis, hypoxemia. We also know that there can be a degree of reperfusion injury, bleeding thrombosis related to systemic anticoagulation. We've heard already about impaired cerebral autoregulation, and we also know that there can be cerebral venous hypertension post-cannulation, which at this moment in time we're not able to measure really well. So multifactorial. And there are very few things we can modify. Looking at the incidence, I'm going to quote some figures here, which are all from the ELSO registry data, and you can see this is a study published in 2013. Out of the 7,000 neonates supported, 20% had neurological complications, and the risk factors were patient factors, pre-ECMO severity of illness, prior ECMO exposure, and VA ECMO. Another study here, again from the ELSO registry data, you can see 14% of children, neonates with congenital heart disease supported on ECMO had neurological injury, and in-hospital mortality was higher in those with neurological issues. And looking again at the patterns of brain injury in newborns treated with ECMO, you can see this is post-ECMO MRIs showed that 46% had parenchymal injury, 6% had infarction, mostly vascular territories. So what I'm trying to highlight here is that neonates have higher degree of, are at high risk of getting neurological complications. Looking further into what are the factors associated with this, and from this very nice study, a multi-center prospective study, we know that intracranial bleeding is higher than infarction in neonates on respiratory ECMO, and similar percentages were seen in neonates on cardiac ECMO. The most common organ system after surgical and cannulation site bleeding is the CNS, and the prevalence again did not differ between cardiac and non-cardiac groups. And another study from the ELSO registry looking at pediatric cardiac surgical patients showed that 12% developed stroke on ECMO, and those with stroke had higher in-hospital mortality. So these are a series of slides which I'm going to show quickly, showing you the complications reported on the ELSO registry, and this is from the latest report. 5.2% of seizures in the neonatal respiratory group, 5% hemorrhage, and you can see that the survival is affected by the in those who've had neurological complications. Neonatal cardiac group, 6.3% seizures, 4.7% hemorrhage. This is from one of our patients who post-cardiac surgery went on to ECMO, had continuous EEG, which showed acute phase with very frequent seizures, and you can see we are also getting some AEG out of it. And on the AEG, I always say that when you start seeing a steeplechurch effect, that's when you know that the child is seizing. So here, again, looking at the respiratory, again, from the data from the ELSO registry in pediatric respiratory ECMO, you can see 3.2% of children who have neurological complications, seizures, or CNS infarction, and pediatric cardiac, again, about 5%. So what I'm trying to highlight here is that the numbers don't seem that high. Now, we know that there's been a steady increase in provision of ECPR, and children with ECPR will have higher risk of neurological complications. And what we know is, again, from the registry data, that 13.5% of children, of neonates reported with ECPR have seizures, and about 6% have hemorrhage. And you can see that the survival rate is very low, and in some going down to as much as like only 17%. Again, looking at the pediatric ECPR, 10.2% of children have seizures, and about 8% have CNS infarction, and another 8% have diffuse ischemia. Now, I want to start just to highlight this fact about VA ECMO. We know that even in respiratory ECMO, there's an increased proportion of children who are getting carotid artery cannulation. And again, we hear this, that one of the consistent factors as a risk factor for neurological complications is VA ECMO, and that is related to carotid cannulation. And so coming back to this point of what are our modifiable factors for neurocomplications, patient selection, identifying the severity of illness, go early before the child's super sick or has had a cardiac arrest, timely deployment of ECMO, careful initiation of ECMO. You're moving a patient who is either shocked or acidotic or hypoxic to a high flow, high oxygen state, and I think to be very mindful of how you manage that transition, refining ECMO management strategies, neuromonitoring, neuroprotection, and hypothermia. And this incident, all that I showed you so far from the ELSA registry data, in all probability, this incident is an underestimate. And we know that the rate of occurrence and outcome of neurological injury has not changed in recent times, despite significant improvements in our understanding of ECMO and in our delivery of ECMO. So now looking at this baby post-cardiac surgery, you can see that bedside clinical examination is important, but by and large, most of our babies are sedated, muscle relaxed, and it's always very difficult to assess the neurological state. We're using more and more ultrasound and looking at things like the optical nerve sheath diameter, pupillary reaction, especially for a child who's got edematous eyelids. But still, we're still learning, and our neuromonitoring at best is still quite limited. So looking at how do we characterize injury, and there are not that many studies available, and you can see that studies from 1987, some time ago, they looked at the neuroimaging scores, and we have from these papers different scores depending on what the abnormal finding is. And the same thing has been used by Lakshmi Raman's group in another study looking at routine neuroimaging and understanding it better. And what they found was that this neuroimaging score did work well, but interestingly, clinical suspicion performed poorly. And again, looking at from the machine learning that they have been studying, clinician judgment had only 39% sensitivity and 69% specificity. So we all need to get better in identifying neurological injury, and we know that there are multiple limitations, particularly the fact that neurological examination is not sensitive enough and imaging needs standardization. We also know that a lot of injury can be silent, and this is from follow-up MRIs. You can see that they can be punctate microhemorrhages. You can see subdurals too. And when you look at CT abnormalities and imaging utility, you know that head ultrasound scan is insufficient to rule out infarction. And predominant infarction is the middle cerebral artery territory. Commonly arterial and bilateral, and EEG seizures are increased 7-fold in the presence of infarction. So we have this, always this dilemma. Can neuromonitoring and neuroimaging help with neuroprotection? Because at the end of the day, that's what we wanted to see. We may not be able to prevent every complication, but can we mitigate? NIRS, we use it, but there is no universally agreed intervention algorithms. We know that global measurement with refinement of signal may indicate impaired cerebral autoregulation and a safe range, perhaps. We know that with EEG, continuous EEG improves seizure detection and can identify ischemia, very sensitive to identify ischemia, but it alone cannot predict neurological outcome. And MRI, which you can do after, can help you with identifying lesions, probably the severity, and prognosticate for clinical indications. So I'm coming to the end of the talk. So neurological complications are seen in 5 to 10%, as I said, underestimated in the ELSO registry, but much higher, in up to about 40% in published literature. Neurological examination is insufficient. Neuromonitoring is not reliable. There might be silent neurological injury, much more common in neonates. There are multifactorial causes for neuroinjury, pre-ECMO, on ECMO, post-ECMO. Few are modifiable. We know that those who have neurological complications have higher mortality, and those who survive will have later adverse neurodevelopmental outcomes. Mitigating neuromorbidity on ECMO needs a comprehensive care bundle, and there is no clear evidence as such for neuroprotective strategies. Early recognition, timely intervention, and post-ECMO care are crucial. But what can we do as an ECMO community? How can we reduce this? We need more research to identify and minimize neuro complications. What is it that targets these children to get neurological complications? Is there inflammation? Is there endothelial activation? And Melanie Bembier's group is looking at this. We've already heard about early recognition with continuous monitoring of cerebral autoregulation. But I think it's crucial to understand the mechanisms of cerebral autoregulation, inflammation, study these neuroprotective mechanisms so that we can apply. We know that there are a few European studies. We know that there is a biomarker studies coming up, and we heard all about the hydrogen fast study in yesterday's research talks, and I hope that more and more from the ECMO community will get studies, and I'm really happy to see that most of the studies, physiological studies on ECMO, are now using neurodevelopmental outcomes as one of their markers of outcomes, so that's really good. Now, what else can we do? We need to collaborate as ECMO community. We have the ELSO Neuro Working Group, and we are producing work as a group. Now, we did an international survey of neuromonitoring and neurodevelopmental outcomes in Europe, and what we found across many ELSO and non-ELSO centers that there is marked variability. There's absolutely marked variability in the neuromonitoring, the neuroprotection, and the neurodevelopmental follow-up. We need to develop guidelines, practice policies, collaborative QI learning. I just sort of put this up as a sort of reminder for myself, is that you have to remember that children supported on ECMO are at high risk, whatever the reason for ECMO may be. Early ECMO, patient selection is important. Anticipation and close monitoring at all times have a very low threshold for intensifying monitoring or undertaking neuroimaging. Understand the mechanisms, the timing, and the consequences of brain injuries to develop interventions. So neuromonitoring, neuroresearch is important to mitigate neuromorbidity. We have to develop evidence-based protocols for neuroprotection, and these protocols have to be evaluated and informed by outcome data. And finally, you have to have robust, protocolized follow-up so that these children can be assessed and followed up for neurodevelopmental outcomes. So my take-home messages are maintain best practices, anticipate high-risk population. It's a continuum of care from initiation of ECMO to discharge from hospital. Always include multidisciplinary assessments. It's sometimes our bedside ECMO specialists and physiotherapists who alert us to some neuro issues. Intervene early, treat immediately, constantly review and reevaluate. Remember that there is silent neurological injury. Be vigilant at all times. And finally, educate. Educate the wider team, educate the parents, educate the family. This is a lifelong trajectory for them for neurodevelopmental issues. So with this, I'd like to thank you for listening to me, and we'll take questions at the end. Thank you.
Hello, and thank you for asking me to give this talk. So actually the talk was prefixed with the words rare but devastating anterior spinal cord stroke. And those three words, rare but devastating, are quite important for the talk. It's actually so rare, I've never actually seen it associated with the ECMO, but unfortunately I have seen anterior spinal cord strokes in part of my other work is because we work in quite a significant aortovascular centre. So a lot of what we'll talk about also relates to that. So I have no disclosures to declare, so moving on. There's not a lot of literature out there about anterior spinal cord stroke in VA ECMO. These are the two main case series you'll see out there, and I present some of their data, and I have to thank them for their work. The top report published in Journal of Artificial Organs comes from La Pitié in Paris, and then the bottom one on the right comes from Melbourne and the Alfred there. And these report a series of patients. Now, they estimate, based on their single centres, that the incidence of anterior spinal cord stroke is around 0.3 to 0.6%. So it is rare. Obviously, there's some patients who have cardiogenic shock and go on VA ECMO who die, and we never get to truly assess whether they have a stroke. So we don't really know the incidence, but that's a ballpark figure from these two case series. And we're talking about 15 patients in those two case series in total. The patients they describe are characteristically very sick. They've all got severe cardiogenic shock. They've either failed to wean from cardiopulmonary bypass, and they're really in Sky Class E, in the extremist group of patients. There's a range of ages in there. It's not a disease particularly of the elderly. It's a range of ages you would see who are supported on VA ECMO, really. And the levels of which this spinal injury occur vary, but they generally tend to be around the high thoracic level, so T1 to T7 or A type levels. And the functional outcomes in these patients are poor. They include paraplegia and lots of bladder and bowel type problems, and hence the word at the start about devastating. And a third of them subsequently went on to die of either multi-organ failure or their primary illness. So these are a sick group of patients. And these are the typical MR figures you see. So it's not just affecting one level in the cord. You can see these are T2 weighted images of the spinal cord, but you see this bright signal going in a long way down the cord. You see it in cross-section here. This is going right down their cords from like the mid-thoracic level and down. So they have quite profound neurological effects. And just to take you back a little bit into the anatomy of the blood supply of the cord, it is surprisingly tenuous, really. I'm kind of surprised it is. There's this tiny little central artery in the spinal cord. It's not much. Most of the blood supply from the cord comes from the pial arterial plexus around the cord, which is supplied either by the artery of Vedankovich, which we all remember from anatomy at school, or at medical school, but also from connections to the lumbar arteries and things. And it's kind of perfused from out to in. So the central part of the cord is particularly vulnerable to ischemia. And then if we think of it in how those vessels are supported, particularly of the anterior spinal artery, that's the main feeder into the anterior spinal artery comes from your vertebral arteries in your head, and then some cauda-equina arteries, and possibly supported by this artery of Vedankovich. But it shows the vulnerability in your cord is related very much to the central bits and the anterior bits. And if you think about the spinal pathways that's associated with, it's this grey matter at the centre of the cord that's particularly vulnerable, and particularly the anterior horns here, which is where our lower motor neurons go and supply our skeletal muscles. The lateral corticospinal tracts are very vulnerable, as are the anterior corticospinal tracts. So this gives us the paraplegia, the flaccid paraplegia associated with anterior spinal stroke. And what are the causes of this? So hyperperfusion I put at the top of the list. Certainly in aortovascular surgery, the most common time you see the MEPS go, and I'll come and talk to MEPS, is where we have a problem with perfusion, either due to hemorrhagic shock happening in the patient or cardiogenic problems. Or it can be local. It may be that the surgeon has not implanted those lumbar arteries when they're doing their thoracoabdominal aneurysm repair. It could be embolic, cholesterol, plaque, or clot. Those MRs don't look like the wedge-shaped things you see in infarcts, and it tends to be sustained throughout the cord. So it really suggests that it's much more a hypoperfusion problems. I've seen comments in the literature saying it was possibly just due to altered flow in your aorta, that interface between ECMO and native cardiac output, the things we talk about in reference to things like Harlequin system. I don't quite understand that. I put it up there for completeness. I don't really get it. I think it's much more a hypoperfusion problem, maybe some form of embolism. And then there's the dynamics of CSF production. Classic teaching says you put an aortic crust clamp on and the CSF production goes up. I don't think that's true. I think it's been proven. But certainly, where we have neurological injury, the whole dynamics of CSF production and cerebral spinal cord perfusion pressure changes at that point in time, which can exacerbate any hypoperfusion situation. And there's associations out there with the uses of intra-aortic balloon pumps, which of course are moderately common on VA ECMO, and cerebral coronary angiography, which is very common probably on VA ECMO. But most of what we know is really related to aortovascular surgery, of people repairing these descending thoracic aortic aneurysms, either with open techniques or increasingly so with endovascular techniques. So there's a very big association with paraplegia in these procedures. The likelihood of your paraplegia is very much related to your Crawford classification or the length of the endovascular repair. So extent 2 type procedures, which are virtually the whole length of the aorta, you're much more likely to become paraplegic with. The slight difference here is, though, we know the time of our insult. We know we're doing something to the aorta and the perfusion, and therefore we can be a little bit more proactive about observing it and managing it. So the mainstay of managing this is to maintain people's spinal cord perfusion pressure. And targets that typically we use in our centre is one of over 70 millimetres mercury. And we calculate that just from the mean arterial pressure minus the CSF pressure. And we do that by hypertensing the patient to a certain extent, to a mean of 80 to 100, and maintaining the CSF pressure below 20 with a spinal drain. And we monitor for it as well. We do motor evoked potentials in theatre whilst the patient's sedated, which is where we're stimulating the brain and we're watching the motor signal in the big toe usually. And if those MEPs disappear or suddenly we wake the patient up and they aren't moving their legs, then we move into what we call our COPS protocol, which is a little bit empirical, but it's what most people use based on the literature. And this is where we try and reduce the CSF pressure further so we get a better perfusion of the spinal cord. We try and improve oxygen delivery by aiming SATs of over 95%. For intensivists, we'll liberate our hemoglobin target and get it over 100 grams per litre. And obviously, we're going to maintain a cardiac index of 2.5. I hope we do that most of the time anyway, really. We manage their systemic blood pressure. We tend to hypertense them even more. We're aiming MAPs of over 90 at that point in time. And we try to get that spinal cord perfusion pressure up. And then we continually assess the patient. There are comments about whether acetazolamide, that has impacts on CSF production, whether mannitol and dexamethasone impact. Don't think there's any strong evidence for any of those interventions. So that's how we try and rescue a cord that has just been damaged. But the point is, it's just been damaged. It's not something that has occurred some time ago. Which leads us to the difficulties of this complication in VA ECMO, because its detection is really difficult. Most of our patients are often unconscious. I know we do more awake ECMO. And a lot of our patients are very sick. These are Sky Class E type patients. So these are the types of patient we wake up with terrible ICU-acquired weakness. And it may only become apparent that their legs don't move once their arms have recovered several weeks down the line. And there's in the aortovascular world, some present late because it's more of a secondary neurological injury in the thing, and that just muddies the picture. It's not really practical for us to do MR in our VA ECMO patients. I don't know of an MR safe or MR conditional pump yet. And again, things like motor evoked potentials, it's a massive resource we plump into aortovascular surgery because we need skilled operators. I'm not sure we're quite there yet for all VA ECMO patients. And then the management of it is different. I talked about our COPS rescue protocol, but spinal brains are tricky in anticoagulated patients. Yes, we're all much more comfortable about running VA ECMO off any form of anticoagulation for periods of time, but it does have its risks. And systemic hypertension is really difficult on VA ECMO. Hypertensing a patient then causes us all kinds of problems if we have got a failing heart or we're trying to unload the heart and things like that. So actually the rescue protocols have become very difficult. So really, there's not a lot you can do when you detect it. And I think our focus really probably should be on the enablement of the patient afterwards. And this is where it's us being good ICU doctors and nurses and therapists that it really comes into the aim. And it's trying to make the devastating bit of this spinal cord stroke slightly less devastating for the patient. And we obsess about these things, so particularly bowel and bladder management. We're very proactive about bowel management. We utilise the patient's gastrocolic reflex, so we're aiming for their bowels to open 30 minutes after we fed them. We try and get them onto oral diet as quick as we possibly can. We use standard things like abdominal massage, stool softeners, and digital stimulation to try and make their bowels work at a more socially acceptable time. It's all about bladder management. It's all about just good intensive care in terms of our nutrition and particularly our skin care in these patients. There's a lot about psychosocial support. And then actually the physical enablement becomes much later down the line. It's about getting those basics of critical care right before we go on to physical enablement. To get into specialist neurological rehabilitation, you have got to have a certain amount of exercise tolerance to benefit from it. It's not something you can just leave the ICU, go to specialist neurological. It's demanding stuff, neuro rehab. And you can't have a catalogue of whole other problems like skin care problems and nutritional problems to get a good outcome in that route. Their physical enablement very much depends on the level. On the ICU, a lot of our time is spent at just about maintaining range of movement, which is really important for them, and maintaining their upper limbs. If their upper limbs aren't affected, those are the things that are going to help them enable afterwards. So really, the summary is probably more common than reported, but it's common in those patients that actually don't survive with cardiogenic shock on VA ECMO. Its prevention is difficult. Maybe we could monitor MEPS in all our patients, but that's a big undertaking, especially the volume of VA ECMO we're doing for cardiogenic shock nowadays. Maybe we should have more of our patients awake. It's something we desperately try to do. There's often other barriers preventing that. Aortovascular surgery can guide us somewhat, but really I think the thing about it, the secret is it's about enabling the patient just to try and make that devastating bit slightly less devastating. Thank you.
So good evening, everybody. The last lecture, I hope not the least. Thank you very much for still being around. It's really great to see so many people still being here. Dear Ravi, dear Aparna, I'm sorry I'm talking about the adult population now because I have very few ideas about what we have to do in children. Maybe a few of my hints will be true for pediatric population as well. We may discuss later on. I have nothing to disclose. And I actually want to start with this study from a French ICU who looked actually into the mode of death in their patients post-resuscitation. There were more than 1,100 patients, of whom 66.7% deceased, and 34.8% were due to shock and 65.2% due to neuroinjury. And when you look a little bit closer, in the beginning, many of these patients died due to shock, and this is maybe where ECMO can decrease the large number of early death. Yeah, we may be able to bridge these patients, but a huge portion of patients actually die of neuroinjury. Now, I think from your clinical point of view, you will agree in many we will not be able to improve that, but maybe there is a portion of these patients where we might get better in our early treatment and hopefully decrease this very high number of neurological injury in our population. What are potential points of action? Where could we look at? And these are many things we could discuss, and I'm afraid it would spoil your evening. So I will go mainly into 3 points. I want to talk about PaO2 because we have new data now. I want to talk a little bit about mean arterial pressure. What should we aim at? And is pressure the only thing we should look at? Of course, we should go into oxygen delivery. This is flow, very much important. I'll come back to that. This is, of course, saturation and it's hemoglobin. I'm not going to talk about hemoglobin, but there is some data that higher hemoglobin will have a better neurological outcome. And I will talk a little bit towards the end about PaCO2. We have already heard in the first lecture that CO2 is so important. Of course, pH plays a role. Reperfusion fluids is a very interesting topic where I think we will talk about in 5 years' time. You are probably aware that in Nature there have been 2 interesting publications that with different reperfusion fluids you may be able to even revive organs and the brain in animals. There is the big question, could pulsatility improve outcome? Should we have devices which cause pulsatility? Question mark. And of course, we could also reduce the metabolic demand, for example, by cooling our patients. But let's talk about the first 3 in the coming few minutes. I think we all agree that we need oxygen. If we have too little, it's bad, but if we have too much, it's bad too. And we all know that oxygen is toxic per se. It is highly reactive. It oxidizes lipids, damages DNA, and you are aware that we have many mechanisms in our body which actually function as antioxidants to provide our organs. Now, if these are overwhelmed, we get problems. We get the damaging problems with oxygen. And we are quite aware that hyperoxemia has to be avoided. It reduces cardiac output. It increases systemic vascular resistance, which is bad because it reduces flow. It decreases coronary blood flow, decreases cerebral blood flow, and causes neurotoxicity. So that is shown in many studies. And that is also why we have a number of trials, I'm not going into detail, which actually try to find out, is it better to have our patients in the ICU on a liberal oxygen or on a more conservative oxygen, PaO2. And I'm not going into detail, more or less there was no difference. Whether you go conservative or liberal oxygen targets, there was no big difference. So actually what was urgently awaited is the BOX trial, which fortunately came out a few weeks ago, you are probably aware. And that was a huge prospective randomized control trial from Denmark. They had 4 arms. They compared both PaO2 in 2 arms with a PaO2 of 68 to 75, conservative PaO2 versus a more liberal PaO2, 98 to 105 millimeters of mercury. And they had another 2 arms with a different mean arterial pressure, 63 millimeters of mercury versus 77 millimeters of mercury. Fortunately, that came out just in time to present it to you. What was the result? Well, 789 patients with out-of-hospital cardiac arrest, sustained ROSC, so a very big study, PaO2 around 70 versus close to 100, no difference. So probably it's not all that important. I think important is that you don't have hyperoxemia. But whether we run at 65 or whether we run close to 100, probably, at least in this big cohort, did not make a big difference. The same group looked into mean arterial pressure. Now, let's first summarize what I think about hyperoxemia. I think we more or less all agree today has to be avoided after ECPR. And you are all aware that it's very dangerous. When we put somebody on ECMO, there is a high risk that we have very high PO2s post-membrane. When your membrane is working properly, you will have a post-membrane O2 of around 500. Therefore, we need a blender. That's mandatory in ECPR from the very beginning. That's especially important when you do out-of-hospital ECPR. I think you should aim at a post-membrane PO2 goal below 150, 120 to 150. I think you have to be a little bit on the safe range because you still may get some mixing by the heart. So we would aim at post-membrane PO2 goal between 120 and 150 millimeters of mercury and would aim at a PaO2 goal between 70 and 100 millimeters of mercury. be aware of the possibility of Harlequin syndrome to develop. When the heart is recovering, which it hopefully should do, then you may get mixing of poorly oxygenated blood from the heart. Be aware that your membrane may deteriorate overnight. You have to regularly check your post-membrane gases, and be also aware that your patient, when you warm him up again, he may have a higher oxygen demand and may need more oxygen. I told you the same group looked into mean arterial pressure, a map of 63 versus 77 millimeters of mercury. Again, no difference. Virtually the same outcome. What would I take as conclusion in ECPR? Now, these are ECPR patients. I would say probably a mean arterial pressure of 65 is sufficient. I'm not sure whether everybody agrees. I know some people who say post-resuscitation you need 85. We aim at 65. The study showed that lower is enough. And do remember, we are not just treating the brain, we also have to look at the other organs, especially the heart. We have to give the heart a chance to recover. And your mean arterial pressure is actually what is the afterload for your heart. It's not ECMO flow, it's mean arterial pressure. So whenever you go higher in mean arterial pressure, it's more difficult for your heart to recover. Therefore, I would suggest 65 is sufficient. If you have higher mean arterial pressures, and it does happen after ECPR because you get vasoconstriction, you will have higher ventricular load, you have a reduced ventricular recovery, you have the risk of pulmonary edema, you get ventricular clotting, and you will have, of course, a higher need for additional interventions, which means, again, you have more complications. So when you aim at 85 mean arterial pressures, you will need more impeller and unloading of the ventricle. Remember, flow is decisive. It's not only pressure, it's flow which is the most important. You all remember oxygen transport capacity, hemoglobin is saturation, is flow. So we have to aim at high flows, and I actually have to tell you it's difficult to measure whether we have sufficient flow, because these patients often have constricted vessels, and your ECMO may just pump 3 liters and you have sufficient pressure and you think it's enough. It may not be. You have to look at your highest possible flow. How could we monitor? We could look at lactate, we could look at cerebral oxygenation, we could look at central venous saturation. Last but not least, and I think that's where we do most wrong, this is CO2, and we have heard already CO2 is dangerous. We have, I think, enough data now that lowering CO2 rapidly does increase neurological injury. You know that low CO2 results in vasoconstriction and secondary bleeding, so that must be avoided, and the danger is very high when you use ECPR. This is nice data we couldn't do probably today anymore, but they measured actually in 10 patients post-resuscitation the oxygenation in the jugular bulb and did hyperventilation, normal ventilation, and hypoventilation. And they could show that actually your flow on hyperventilation went down. When your CO2 goes down, your flow goes down, and the oxygenation in the brain actually decreases, and also in the jugular bulb decreases. So I think it's without doubt, if we hyperventilate our patients, if our CO2 is too low, the saturation in the brain will decrease, which is poor and bad. That was a small but interesting study from Australia, multicentric, randomized only 86 patients after CPR, and they had an intervention, either looked for normocapnia or mild hypercapnia with a PaCO2 between 50 and 55 millimeters of mercury. Good functional recovery actually was in both groups, not too bad. It was slightly but not significantly better in those who had slight hypercapnia. And they could also show that those who had slight hypercapnia actually had less neuron-specific annulase. So my suggestion today would be the risk of hypocapnia with ECMO is very high. The risk is really exceedingly high. Therefore, immediately adapt your post-membrane PCO2, adapt your ventilation for PaCO2, and aim at normocapnia or even slight hypercapnia. To summarize, and that's from a clinician's point of view now, my suggested targets for ECPR in 2022 would be military pressure of 65 millimeters of mercury, PaO2 between 70 and 100, PaCO2 45 millimeters of mercury, and implement as early as possible, preferably automated inline post-membrane blood gas analysis, and if possible, a blood gas analysis in the aortic arch, because that mirrors what's probably going up in the brain. And you see here we have an adapter here, and we actually put up a small catheter in the aortic arch, and we measure both pressure in the aortic arch post-resuscitation, and we measure blood gases. Because in these patients, often you can't monitor in the beginning. You have to have a continuous invasive blood pressure measurement, and we also start from the very beginning to measure our tissue, our cerebral tissue oxygenation. So I think necessary or useful is a portable NIRS, is a portable O2 blender, which you have to use when you do out-of-hospital resuscitation. Portable blood gas analysis and tidal CO2 might be helpful, and the central venous saturation. Thank you very much.